bony section of the spinal cord. It is also called the Brown-Sequard syndrome. Today about complete transection of spinal cord. Complete transection of the spinal cord. It means spinal cord is completely transected. Completely transected. What is the cause of complete transection? Fracture dislocation of vertebral column. Fracture dislocation of vertebral column by a bullet, stab wound, or by a tumor. Right? So fracture dislocation of the vertebral column by a bullet, stab wound, or a tumor. It results into complete transection of the spinal cord. Now after the complete transection, if transection is in the lower cervical segments of spinal cord, transection is in the lower cervical segment of spinal cord, there will be quadriplegia. Quadriplegia. All the 4 limbs are paralyzed. So quadriplegia results when the complete transection is in the lower cervical segments of the spinal cord. When the spinal cord transection is in the lower thoracic segments, then there will be paraplegia. There will be paraplegia when the transection is in the lower thoracic segments of the spinal cord. What do you mean by paraplegia? When both legs are paralyzed, it is called paraplegia. Now after the complete spinal cord transection, there will be stage of spinal shock or stage of flaccidity. So stage of spinal shock or flaccidity. So in this stage of spinal shock or flaccidity, there is flaccid paralysis. Flaccid paralysis below the level of transection. Flaccid paralysis, loss of all the voluntary movements, loss of muscle tone, loss of superficial and deep reflexes, loss of superficial and deep reflexes, loss of all the sensations, loss of all the sensations. Muscle tone is also lost in the smooth muscle. It is lost in the sphincters. I mean anal sphincter, urinary sphincter. Anal and urinary sphincters, they lose their tone in this stage. Muscles of the body lie in the position imposed on them by the gravity. Muscles of the body lie in the position imposed on them by the gravity. Right? So loss of all sensations, loss of muscle tone, even the smooth muscle, even in the sphincters, loss of all superficial deep reflexes, right? Loss of all the movements. This occurs in the stage of flaccidity or spinal shock. So what is the cause of the spinal shock? The cause of spinal shock is loss of tonic excitatory impulses to the spinal cord neurons along the corticospinal, reticulospinal, and vestibulospinal tracts. So loss of tonic excitatory impulses to spinal cord neurons along the corticospinal, reticulospinal and vestibulospinal tracts. So these impulses which are excitatory, these tonic impulses are coming along these tracts to spinal cord neurons to maintain their excitement. And their loss results into stage of spinal shock or flaccidity. In this stage, of course, the legs are paralyzed. These become pale, cold, maybe cyanosed, maybe cyanosed. Now, spinal cord transection is in the segment, thoracic segment. Then there is loss of the sympathetic tone, vasomotor tone, vasodilatation, fall in the blood pressure, and the legs become cold, pale, or cyanosed. Now, this state of spinal shock, it lasts for 2 to 3 weeks. It lasts for 2 to 3 weeks. Now, after this stage of spinal shock or flaccidity, the next stage is stage of reflex activity. Stage of reflex activity after the stage of spinal shock or flaccidity. Now, in this stage of reflex activity, muscle tone begins to appear. Muscle tone, it begins to appear. It appears in the smooth muscle. It appears in the sphincters. It appears in the sphincters. Inner sphincter, urinary sphincter, these now develops tone. And this results into retention of urine and feces. It results into retention of urine and feces. Vasomotor tone also begins to appear. Vasomotor tone also begins to appear because the sympathetic neurons in the spinal cord learn to function without excitatory impulses from the heart centers. In the spinal cord, sympathetic neurons learn to function in the absence of excitatory impulses from the heart centers. So vasomotor tone, it begins to appear in the blood vessels. So when vasomotor tone begins to appear in the blood vessels, blood pressure increases. Blood pressure increases, blood flow to different parts of the body improves. So blood flow to different parts of the body improves. But then muscle tone begins to return in the skeletal muscle. It begins to return in the skeletal muscle. First, it appears in the flexors. First, it appears in the flexors of the body. Flexors become less flabby. These become less flabby. And tone appears in the flexors. By these patients, there is flexion at the hip and knee. There is flexion at the hip and knee. And this is called paraplegia inflection. Paraplegia inflection. paraplegia in flexion. Right? So there is flexion at the hip and knee, and this is called paraplegia in flexion. This is an important feature of the complete transection of the spinal cord, that is paraplegia in flexion. But keep in mind, the muscle tone which returns in the skeletal muscle is not as much as the norm. The muscle tone which appears in the skeletal muscle is not as much as the norm, because the myotatic reflex is weak without the excitatory impulses from the higher centers. Because the myotatic reflex is weak in the absence of excitatory impulses from the higher centers. Now, spontaneous or involuntary movements start in the muscles. Spontaneous or involuntary movements start in the muscles. Say, in the toes, in the foot, there will be spontaneous, involuntary movements, these start. Flexor reflex can be elicited. Flexor reflex can be elicited, and it is accompanied by crossed extensor reflex, accompanied by crossed extensor reflex. Of course, first response will be less, then gradually the response will increase. In many of these patients, there will be mass reflex. So mass reflex in many of these patients. What is mass reflex? When the skin on any part of the legs and anterior abdominal wall is scratched, and the skin on any part of the leg or anterior abdominal wall is scratched, there will be three responses. Contraction of the flexors of the leg, contraction of the flexors of the leg, contraction of the muscles of anterior abdominal wall, contraction of muscles of the anterior abdominal wall. The other feature is evacuation of the urinary bladder, even if it contains small quantity of urine. So evacuation of urinary bladder, even if it contains small quantity of the urine. And this is due to contraction of the muscles of the anterior abdominal wall, contraction of the muscles of the anterior abdominal wall will increase the abdominal pressure. There will be compression of the urinary bladder. So this results into evacuation of the urinary bladder. The other feature of the mass reflex is profuse sweating below the level of the transection. So these are the features of the mass reflex which can be elicited in these patients. Now keep in mind that at this stage, in males, erection can occur by stimulation of the glans penis or genital organs. So erection can occur in males by stimulation of the glans penis and the genital organs. At this stage, in the patient with spinal cord transection, complete transection, below the level of transection, there will be features of upper motor neuron lesion. So features of upper motor neuron lesion. Below the level of complete spinal cord transection, there are features of upper motor neuron lesion. Ankle jerk, knee jerk, these appear, these become accelerated. Babinski sign is positive. Babinski sign become positive. Right? So these are the features of the upper motor neuron lesion which appears below the level of the spinal cord transection. And this appears, say, after about 3 months of complete transection, the features of the upper motor neuron lesion appear below the level of the spinal cord complete transection. I mentioned that the Babinski sign appear. We also discussed in the last lecture about the normal plantar reflex and the Babinski sign. This is the normal plantar reflex with the blunt pointed object. We scratch the skin on the lateral border of the sole of the foot. We scratch skin on the lateral border of the sole of the foot. In a normal person, there is flexion of all the toes. You see? There is flexion of all the toes. This is the normal plantar reflex which can be elicited normally in human beings. And this is the normal plantar reflex. Its root value, segment value is S1. This is the Babinski sign, which is positive in upper motor neuron lesion. When we scratch the skin on the lateral border of sole of the foot, there is dorsiflexion. You see, there is dorsiflexion of the big toe and plantar flexion of the other toes. So dorsiflexion of the big toe and plantar flexion of the other toes. Right? This is the abnormal plantar reflex, which is called extensor plantar reflex and the Babinski sign. This is the Babinski sign, that is the extensor plantar reflex. We scratch the skin on the lateral border of sole of the foot. There is dorsiflexion of the big toe and fanning out of the other toes. This is the Babinski sign, that is the abnormal plantar reflex, which is present in patients of upper motor neuron lesion. I told you last time, in addition to the upper motor neuron lesion, this sign is also positive in deep sleep, in infants, and also when there is intoxication, say there is alcohol intoxication, this sign becomes positive. It becomes positive. Right? So I told you about 3 months after the complete transection, the features of upper motor neuron lesion, these appear. Now keep in mind, after recovery, sensations do not recover. After recovery, sensations do not recover. Sensations do not recover. Okay. Now regarding the defecation and micturition. Defecation reflex can be elicited. Similarly, reflex for micturition can be elicited. So there is abnormal, of course, also you can say automatic bladder, you say it appears, automatic bladder. And urine accumulates in the urinary bladder, reflex for micturition is initiated, and this leads to micturition. So there is automatic bladder in these patients of complete transection of the spinal cord, automatic bladder. Similarly, when feces accumulate in the rectum, there will be activation of the defecation reflex, which occurs and which results into defecation. Now keep in mind, these patients learn gradually how to elicit these reflexes. So by scratching around the anus, they can elicit the reflex for defecation. By scratching on the medial side of the thigh, they learn to elicit the reflex for micturition. Right? Now these patients with complete spinal cord transection, with good nursing care, can live for years. With good nursing care, can live for years. But of course, in many cases, there won't be good nursing care. There is neglection. And this results into the next stage, that is the failure of the reflex activity. Failure of the reflex activity. Now, failure of reflex activity occurs when there is generalized infection and toxemia in the patient. When there is generalized infection and toxemia in the patient. It becomes difficult to elicit reflexes. It becomes difficult to elicit the reflexes. Response in the reflexes decreases. Response in the reflexes decreases. Mass reflex disappears. Mass reflex disappears. Flexor reflex becomes weak. Flexor reflex becomes weak. And then bed sores appear. Patient is paralyzed, lying all the time on the bed. So bed sores appear. Bed sores become infected, right? And patient becomes worse and worse. It becomes worse and worse, and ultimately death occurs in the patient if they are not properly managed, not properly cared or managed. Death occurs in these patients. So this was about the complete transection of the spinal cord. Right? Now we come to incomplete transection of the spinal cord. Incomplete transection of the spinal cord. Spinal cord is severely damaged. Severely damaged. But not complete section. Not complete section. Now, the cause of incomplete transection is same. That is fracture dislocation. Fracture dislocation of the vertebral column by bullet, stab wound, or by a tumor. By a tumor. Now after the incomplete transection, there will be state of spinal shock or stage of flaccidity, and then come after 2 to 3 weeks, there will be stage of reflex activity. Stage of reflex activity. In this stage, one important feature is that muscle tone in the skeletal muscle first returns in the extensors. So muscle tone first appears in the extensors. There is paraplegia in extension. There is paraplegia in extension. You see, in these patients, there will be extension at the hip and knee. There will be extension at the hip and knee, and this is called paraplegia in extension. So don't forget, in complete transection, there is paraplegia in flexion. In incomplete transection of spinal cord, there is paraplegia in extension. So in incomplete transection, there will be paraplegia in extension. Why? There is extension in the incomplete transection. Now in the incomplete transection, reticulospinal and vestibulospinal tract. Reticulospinal and vestibulospinal tracts, these are spared. Right? These are not damaged. And you know, the vestibulospinal and reticulospinal tracts are excitatory to extensors. So these two tracts, reticulospinal and vestibulospinal, these are excitatory to extensors. That is why there is paraplegia in extension in incomplete transection of the spinal cord. The other feature will be extensor thrust reflex. Extensor thrust reflex. Extensor thrust reflex, and that is, patient is lying on the back, on his back. Patient is lying on the back, on his back. One leg is flexed. One leg is flexed, and the foot is on the back. So patient is on his back, lying on the back. His one leg is flexed. Foot of the flexed leg is lying on the back. The doctor, with the palm of the hand, exerts upward pressure on the sole of the foot of the flexed leg. The doctor, with the palm of the hand, exerts upward pressure on the sole of the foot of the flexed leg. There will be extension of the leg. There would be extension of the leg. Right? I again repeat, the patient is lying on his back on the bed. His one leg is flexed. The foot of the flexed leg is lying on the bed. The doctor, with the palm of the hand, exerts upward pressure on the sole of the foot of the flexed leg. There will be extension of the leg. There will be extension of the leg because of contraction of the quadriceps and posterior calf muscles. So because of the contraction of the quadriceps and posterior calf muscles, the leg becomes extended or straight. This is called extensor thrust reflex. Extensor thrust reflex. Then the other feature is patient is lying on the bed. One leg is flexed. His one leg is flexed. You see, after some time, the flexed leg becomes extended, and the other leg, which was extended, becomes flexed. I repeat that one leg of the patient is flexed. After some time, the flexed leg becomes extended, and the extended leg becomes flexed. So this is the alternate stepped movement. This is the alternate stepped movement which can occur. Right? So this can occur. Alternate stepped movement can occur. But of course, walking is not possible. Walking is not possible, although alternate stepped movement can occur, but walking is not possible in these patients. Now, after the recovery, in patients with incomplete spinal cord transection, what are the features? Below the level of incomplete transection, they will be bilateral upper motor neuron type of paralysis. Bilateral upper motor neuron type of paralysis below the level of incomplete transection. Right? Then at the level of transection, there will be low motor neuron type of paralysis at the level of incomplete transection. So at the level, there will be low motor neuron type of paralysis. Then below the level of transection, there will be loss of all the bilaterally loss of all the sensation. So bilaterally loss of all sensations below the level of the transection due to damage to the sensory tract. So this was about the incomplete transection of the spinal cord. And don't forget, paraplegia and extension is the feature in incomplete transection. Moreover, extensor thrust reflex is another feature of the incomplete spinal cord transection.